I've got my special Oxford tie on, so I feel nicely at home, very happy to be here. I'm going to talk about the current challenges in pulmonary embolism. So I thought what I would do is obviously going to talk about the challenges, but also some of the solutions to those challenges. Most of the challenges are met, but there are still some difficult and unanswered questions out there which I'll highlight. I have some interests to declare. This pathway here is the European Society of Cardiology pathway, which was published in 2014, so it's reasonably up to date. Of course, pulmonary embolism doesn't move that fast, so it's reasonably up to date. And the way it really differs from the NICE guideline from 2012 and the BTS guideline from 2003 is that there's much more in the way of risk stratification using scoring systems, particularly to guide you towards home management of pulmonary embolism, or potentially things like whether to thrombolyze patients with some additional add-ons such as measurements of RV function. So risk stratification has become a big thing over the last few years in pulmonary embolism. So what I'm going to do is effectively walk through this algorithm here. I'm not going to focus at all on the shocked hypotensive patient because they are they go down this pathway here to primary reperfusion. You can tell this was written by a bunch of cardiologists because starting to use this kind of terminology, whereas we would have just called it thrombolysis. So if we focus really on the right-hand side of the algorithm here, we're talking about the patient who is coming through the front door with a clinical suspicion of pulmonary embolism, who's not shocked, and rather than making an empirical diagnosis and thrombolizing, we need to make a proper diagnosis and then go on and treat appropriately. So this is the sub-algorithm for suspected PE without shock or hypotension. So we still go with the clinical probability of pulmonary embolism, and this is one of the things that is probably not quite so relevant for you guys, but I think it is very relevant for emergency department physicians, acute physicians seeing patients, is trying to get over to the trainees that the risk of a pulmonary embolism is not the same as the risk of the pulmonary embolism in terms of its severity. So you've got, first of all, how we assess for whether or not somebody might have a pulmonary embolism, and then once it's diagnosed, we then further assess whether they are a high risk, intermediate risk, or low risk pulmonary embolism. So we're starting off here typically using the Wells score, or the modified Wells score, and classifying people into low or intermediate clinical probability, or in terms of using the NICE wording, PE unlikely or PE likely. And in the context of pulmonary embolism being likely, then we just go straight for imaging, usually CT angiography. So in the case of a pulmonary embolism being unlikely, then we use a D-dimer to effectively to rule out pulmonary embolism. So if it's negative, then you have to think of an alternative diagnosis. And if it's positive, going on for CT angiography. So one of the things that you'll know much more about than I will is the role of D-dimer and how D-dimer changes with age. So this is quite a nice study. I've tried to focus mainly on studies that have been published in the last couple of years. Of course, I'm now slightly out of date with myself as it's 2017. So this was published in JAMA in 2014, and this was using age-adjusted D-dimer cutoff levels called the Adjust PE study. And the way they defined this was that taking patients over the age of 50, they said, well, let's consider a cutoff level of D-dimer of the age multiplied by 10. So they took 4,400 patients who were eligible, and of these, 3,300 had a clinical probability assessment. This is the group we're interested in here. There were just under 3,000 patients had pulmonary embolism unlikely on the basis of the scoring system, and 817 of these could effectively be excluded on the basis of a classically negative D-dimer. I don't know, is anybody in here using age-adjusted D-dimers in their hospital, or is just still using a single cutoff? No hands up. So we're still all going with this. Now, There were 337 patients, so just under half the number that had a negative D-dimer, who had a D-dimer above 500 but were less than the adjusted age cutoff, so age multiplied by 10. And then there were 1,700 patients who had a positive D-dimer by those criteria. So what happened to these patients? So the ones who would be classically ruled out of having a pulmonary embolism and not going on to have imaging, the 817 patients, go all the way down to the bottom. There was one adjudicated VTE event. So 1 out of 800 with a negative D-dimer had VTE. If we then take the 337 patients who had D-dimers above 500 but less than their age-adjusted cutoff, same thing, 1 episode of VTE. So suggesting perhaps that we could save quite a lot of people undergoing imaging by using an age-adjusted cutoff. Now, I guess this hasn't been adopted in a widespread fashion. Perhaps that's just because we're behind the curve. Perhaps it's because there's still some thought that this needs to be validated further. If we look at a subgroup of patients, so the patients over the age of 74, there were 766 of those patients in that age group. Just under 90% had non-high clinical probability, so would have gone on to D-dimer testing. 43 of those patients, so 43 of 670 patients, 6% had a truly negative D-dimer, and 157 of those had a D-dimer less than age multiplied by 10. So in total, 43 and 157, there were 200 patients with a non-high clinical probability D-dimer. 5 of these received anticoagulation, but out of that, out of the other 195, none of them went on to have confirmed VTE during follow-up. So suggesting that in patients over the age of 74, you might be able to save a quarter of them from having scans. So I think that is a challenge. How do we take this forward in terms of adoption? So that's the sort of the diagnostic pathway. I'm not going to go into any more detail about now, actually, no, there was one thing. The one thing that popped up last year that I thought was quite interesting, and this is not relevant necessarily to you in the acute setting, but in the chronic setting, it is quite important, is what do we do about the really small PEs? So this was published a couple of years ago now, looking at small pulmonary artery defects. So if I just give you a couple of examples, here are 2 CT scans from separate patients, and what you have here is, if I didn't have quite such a shaky hand, you could see a small filling defect in one of the basal subsegmental pulmonary arteries on the left, there and there. And then you've also got something here that looks like a filling defect on the right side in another patient. If you look at this one here and you look at the lung windows, you can see what our pulmonary vascular radiologist calls a breathogram. And in fact, this is just the patient's sort of pulmonary arteries moving in and out of the sort of frame. So negative, but looks positive on here. And this one is just a bronchocele. If you flip it round, you can see this is an airway which is full of gunk. So clearly, there is a potential problem for misdiagnosis. And a number of times that I see a patient in a follow-up clinic with my colleague, Dr. Saluja at Hammersmith, and you've got, say, for example, a young guy who's had a diagnosis of pulmonary embolism, who's got a family history. In fact, there was one case a few years ago where his brother had died of pulmonary embolism, and he was given a diagnosis on something similar to this. And actually, when you went back and reviewed the data, he didn't have a pulmonary embolism. It was reported as one, and I wouldn't criticize anybody for giving him 3 or 6 months of anticoagulation, but you're sitting in front of him and saying, well, you've had a PE, you're a young guy, you're at high risk of recurrence, so lifelong anticoagulation for you. That's, so I think it's important to recognize that just because a radiologist has reported it as showing a pulmonary embolism, it may not always be the case. So I think it's relevant, not just at diagnosis, but also it's very important to follow up. So what they did was they looked at main, lobar, segmental and subsegmental pulmonary emboli. They looked at PE size from 9 down to 3 millimeters, and then they looked at the quality of the scan. And they produced this thing called the free marginal multi-rater kappa. have no idea what it means. I think it's some kind of level of agreement. But what you can see is that as you go from segmental down to subsegmental, or as you go down to under 6 millimeters of in the PE size, and as you go down to an intermediate or low quality scan, either in terms of breathing artifact or contrast timing, that you can see the level of agreement goes right down. So their conclusions were as follows. They said if you've got a pulmonary embolism that's less than 6 millimeters in size, or in subsegmental pulmonary arteries, you should get a second opinion. How often does that happen? Very rarely. So what would I do in that situation if I thought it was dodgy? Now, I've got a brilliant radiologist. I work in a pulmonary hypertension center. So I've got somebody who majors in pulmonary vascular imaging. If she can't call it, or if your radiologist can't call it, then I think in some cases it's worth going for a second imaging modality, such as a VQ scan. There's no point doing it 3 weeks later. You've got to do it then. And so the radiologist should also report the quality of the scan, so you can make a call at that 3 or 6 month point. You know, okay, well, how certain were we that this patient actually had a pulmonary embolism? Because there's a bit of a bleeding risk, or the patient's saying, do you know what, I really can't stand being on these medications. Then you can make a bit more of a balanced, shared decision with the patient about what to do long term. So I thought that was quite fun and quite interesting, and then of course how you handle isolated subsegmental PEs is a whole other story, with some people saying you can just leave them alone. Personally, I'd probably anticoagulate them for a short period of time, but not extensively if there was a low bleeding risk. So that's a bit of a challenge for us. Now, once we've confirmed our pulmonary embolism, our next task is to assess the clinical risk, and this is done with loads of different scores, but the one that seems to have risen to the surface is the PESI score, PE Severity Index, which is, I think, 11 scores. It's amazing how that puts a lot of people off. I mean, we've all got multiple degrees. We can all add up, but there is something off-putting about a complex score. So there's a simplified PESI, which is just a 6-point score, and if you score one of those, then your PE-related risk of complications at 30 days is about 10%. So there's a scoring system that we can use, and if I focus first of all on the left-hand side here, so PESI class, that should be 3 to 5, or simplified PESI 1 or more, you're deemed intermediate risk. Now, it's fairly crude, 10% a complication rate. You know, can we refine that further? And what the ESC have said, and it's not wonderfully evidence-based, and I would think the next iteration would come out would be a bit more evidence-based. If they said, well, do an echo or a CT scan. On the CT, you get it for free. You can look at the ratio of the right ventricle to the left ventricle, and if it's greater than 1 or 0.9, some people say, then that suggests there's right ventricular dysfunction. So the other thing you can do is lab testing, so serum BNP, brain natriuretic peptide, or troponin. So if you have RV dysfunction on imaging plus a positive biomarker, then you would be deemed intermediate high risk. And then you would anticoagulate, potentially monitor the patient in a slightly more high dependency environment, and consider rescue reperfusion if they collapsed. If you just had one of those positive, then you would go down the intermediate low-risk group. So it's really not clear, and we're starting to use terminology like NICE, like consider or offer, things which aren't really helpful at all. And so when I get called up about pulmonary emboli, so from within the hospital or sometimes out of the hospital, saying, you know, what are we going to do? There are some other things that I might look at to say, do you know what, I really think you should be thrombolizing this patient. And so some of these things as follows. I'm going to present them here. So one of the things that worries a lot of people is when you do the echocardiogram, or you may see it on the CT, is if you see a right atrial thrombus waving around in the breeze. That's very disconcerting, because if that then gets stuck in the tricuspid valve or the right ventricular outflow tract, potentially, I mean, that's what causes PE-related mortality. So what this registry did was say, well, what's the outcome of people who have right heart thrombi? Now, of course, you get multiple types of thrombi. You can get the worm, you can get the sort of adherent clot, and then you can get the one that sort of dangles around like a myxoma. I mean, they've all got different sorts of management in terms of thrombolysis through to surgery in that order. But what they did here was they took all the patients with right heart thrombi, they showed all-cause mortality and PE-related mortality. I'm slightly more interested in PE-related mortality, and what they showed is that if you scored them according to the ESC criteria that I've just shown you, that in fact those ESC criteria still work quite well in terms of unpicking the low risk from the intermediate from the high risk group. But look, you're seeing this horrible drop-off over the first couple of days, 10% mortality even in the intermediate risk group. So I got called by a hospital last week or the week before saying we've got this person with right atrial thrombus. We've rung up the surgeons, they're not interested, what should we do? And I said, just thrombolyze them. It's very simple. You know, this is potentially very dangerous. Just get on and give them systemic thrombolysis. So what you can see here is that although the risk stratification still picks patients out, overall they are at higher risk if they've got a right atrial or RV thrombus. And this is shown here in patients with thrombus and without, and you can see the mortality is pretty much double if you've got in the presence of right heart thrombus, although high risk, intermediate risk and low risk can still sort of be differentiated on the basis of the ESC criteria. So that's one of the things that's going to push me down the thrombolysis route, or potentially surgery if something's straddling a patent foramen of Ailey. The next thing is this old chestnut. What if you've got a deep vein thrombosis? And it's still something that worries me. I mean, I know that when I hear talks from hematologists, you say there's something different about people who get DVTs and PEs. The DVTs don't tend to fragment. We don't know why, or at least that's what I've been told. But I still would worry about this. And this is a meta-analysis that I was fortunate enough to be invited to take part in, which showed that if you had a DVT, then the odds ratio of 30-day all-cause mortality was 1.9. Now, that's all-cause mortality. It may be that in the presence of a high thrombus load, that's reflected by cancer, etc. But nonetheless, if I've got somebody whose right heart doesn't look very happy, but they've got something waving around in the breeze, in the femoral veins or the iliac veins, that again is going to push me towards thrombolysis. This isn't so much a challenge as something that just I came across, which I thought was interesting. I thought I'd put up in front of you. So ultrasonography causing pulmonary embolism. And it's gone back over the years, so from 1970 up to 2012, and they found these case reports. I thought I would just read out a couple to you. So during the compression maneuver, the thrombus shifted and disappeared. Immediately after the compression maneuver, the patient complained of severe pleuritic chest pain and mild dyspnea. This is another nice one. After the compression test, the thrombus disappeared. Patient became tachycardic. I'm not sure, it's probably not just the patient, but so I don't think it happens very often, and I'm not trying to say we shouldn't be doing these, but nonetheless, this is kind of what worries me about somebody whose right heart might be compromised and who's got something that's just waiting. All it needs is ultrasonographer to come along and have a little look, and it's game over. So, and then this is imaging. I mentioned that if the right heart's bigger than the left, that's suggestive of potentially increased mortality, although actually when you add in things like biomarkers and ultrasound of the leg veins, it washes out in terms of multivariate analysis. But this is just quite nice. This is, I know this probably looks like a thrombin molecule or something, but it's not actually. It's a 3D image of the heart. What's interesting here, of course, you can see the right atrium's big, the right ventricle's big, it's bigger than the left, but actually what people notice nowadays is that the left atrium is small because the right ventricular cardiac output is reduced, so the left atrium is underfilled, and actually that makes the left ventricle underfilled. So in this particular study, they found that when they looked at the left atrial size or the RA-LA ratio or the LV size, that the a small left atrium had the greatest predictive power of 30-day mortality. So a big left atrium and small left atrium and a small left ventricle, but the left atrial size is important. So maybe that's something else is going to factor in. But what we're really trying to do is in these patients with intermediate high risk is select out the ones that we should be pushing forward for thrombolysis. Now, thrombolysis is it's a hot topic, and we were supposed to get the answer from the PETHOS study, which I think was published in 2013, where they randomized 1,000 patients with intermediate high risk pulmonary embolism, and they found the primary endpoint was death or hemodynamic compromise. But of course, that wasn't really what I think is the relevant primary endpoint, because they didn't include all the things like major bleeding, strokes, etc. So we haven't really answered the question of whether or not it's safe or the best thing to do. This meta-analysis published 2 years ago took in just over 2,000 patients, and indeed showed that when you thrombolyze patients with PE, then the odds ratio of death is reduced, so 0.57, not crossing 1. I love the way they say, just sort of loftily say, low quality evidence, and these people have been sweating away trying to get the best data they can, and then somebody, often, it's probably, I apologise if anyone in here has written a Cotton review, but often it's somebody who just, it's an epidemiologist who sits in an ivory tower. These guys have been going out and trying to get the best evidence they can, and it's just worse, low quality or very low quality, high risk of bias. Anyway, 2,000 patients, odds ratio 0.47, recurrence of PE is down, but there's an increased risk of major and minor hemorrhagic events. And that was the problem with the PETHOS study. A lot of the patients, not a lot, but there was a significant number of patients who developed intracranial bleeding. And if you look at it, actually, they were largely the patients over 65. So if you take patients under 65 and you thrombolyze them, the risk of major bleeding is significantly reduced. So if I've got somebody, and this speaking to the title, this is a real challenge. If I've got somebody who does have significant RV dysfunction, the biomarkers are up, and they're 50, you know, go on thrombolyze them would be my advice. But if they're 65 and above, and we had one in the Christmas week who was 65, then I'm starting to get jittery. So what are the alternatives? Well, this is the sort of the latest, most expensive way of doing it, and it caused actually quite a stir in our hospital over the Christmas period, and got some backs up. But anyway, this study looked at CT-confirmed pulmonary embolism with an RV-LV ratio of 0.9 or above. And what they used with this ultrasound-facilitated catheter-directed low-dose fibrinolysis. So I guess you're familiar with this from a DVT perspective. So it's the same thing, but just in the lung. And administering a total dose of TPA of 24 milligrams, as opposed to 100 milligrams, which would be given with systemic thrombolysis. The outcomes, I'm not a massive fan of these outcomes. It shows that it works, but actually what you really want to know is what's the composite 30-day mortality, morbidity, major bleeding. That's what I'm interested in. But anyway, what they showed was the right ventricle to left ventricle ratio improved significantly over 48 hours, and there was no intracranial hemorrhage. So the Optimize study, I think, is currently underway, and that's looking at even lower doses of TPA. So I'm interested to see what that shows. So just showing the RV-LV ratio improves, PA pressure improves, and the modified Miller index, which is the index of obstruction of the pulmonary arteries, is down. I've got quite a lot of stuff here, but I thought probably in view of your particular interests, I wasn't going to go into it. I just wanted to show you this, which is that if you look at simple catheter-directed thrombolysis, so you just put a plain multi-purpose, well, not a multi-purpose, a plain catheter in with some side holes in, and you just drip in thrombolysis, you can get a significant drop in the pulmonary artery pressure. Whereas if you use your fancy, expensive ultrasound-assisted system, you can get the same. So there is a real question over whether or not this confers any benefit over just dripping thrombolysis in locally, and also how much benefit over systemic thrombolysis. So I think this is potentially going to have a niche role if we can start to give really low doses in the patients over the age of 65. And that's where I think potentially we can see this coming into play. And that's where I think we should probably be using it in our hospitals. So I'm not sure that really we should be going for catheter-directed thrombolysis at all. I think we either give systemic thrombolysis or we just go for ultrasound-assisted in that niche group. And I suspect in a large hospital like ours, that may be about 10 patients a year, but you could envisage a situation where you might become a regional centre and you could start doing more. So I think there potentially is a role for this, and we need to find where it is. There's a lot of enthusiasm across the pond, but I think people are much tougher on it on this side in terms of the economics. And I think, I can see some of the guys here from the company. So there we are. I think that's a real challenge to know where the best place is to use that. What about IVC filters? Really, I mean, I don't think there's ever been a large amount of enthusiasm for that in this country. But this trial was published in JAMA recently and looked at PE and DVT, or superficial venous thrombosis, and took this group of patients who you might think might be higher risk. So the older patients with cancer, those who had underlying cardiopulmonary insufficiency, so less able to tolerate recurrent PE, ischemic stroke, DVT, and some markers of RV dysfunction. They enrolled 400 patients that they randomized 1-to-1, and they removed nearly all of them. And this was stunningly and beautifully negative, this trial. At 3 months and at 6 months, all the p-values are just completely, then completely insignificant in terms of the event rate, and then overall the event rate was pretty small. So absolutely no role for IVC filters, but you knew that already working in the UK. So finally, we're going to come to the low risk group. So these are the patients with a simplified PESI of 0 or PESI class 1, 2. And the challenge here is identifying those patients we can send home. So already you've got a heads up with the PESI score that they are low risk. And they've got about a sort of 1% 30-day complication rate. So this group from the Netherlands asked the question, well, what if we add in an unnecessary test like NT-proBNP, so we use BNP in our trust, but NT-proBNP is a bit more stable. What if we add in NT-proBNP? Does that make it more safe? And in the end, it turned out to be an underpowered study. So you've got your PESI risk score, and then you've got your clinical decision rule. So if you've got any of these things, it's not a great idea to send you home. So hemodynamically unstable, high risk of bleeding, needing oxygen, etc. A lot of that overlaps, and if you had any of these, your PESI score would be up anyway. So, but they just used this rule-out score, and if you didn't get any of those, you could be then randomized to direct discharge or having your NT-proBNP disclosed. They all had it measured, but half of them had it disclosed. And 12% had an elevated NT-proBNP, and they were managed as inpatients. And what they found was that actually there was no difference in the primary endpoint, so 0 versus 1.1%. So 1.1% reached the primary endpoint if they were directly discharged. And you might say, well, maybe actually that's important, and those patients would have been picked up. Those are the ones, they also had a negative NT-proBNP. So the conclusion from this study was that if you just use the Hestia criteria alone, you can send people home with a low risk of adverse events. But they felt it was still unable to draw definite conclusions. Now, you could say if you need to do a study which has got 10,000 patients in it to find a difference, well, probably it may be statistically important but clinically irrelevant. So that's probably where we are. We can use a simple scoring system alone to send people home. What can we send them home with? So in the dark ages, we'd send them home with low molecular weight heparin and warfarin. And now in the sort of enlightened Donald Trump era, we are able to, sorry, that's terrible taste, isn't it? Anyway, so we can now think about sending people home directly with DOACs. Now, of course, there are two DOACs, which can be used as a single drug. You know this stuff much more than I do, but obviously rivaroxaban and apixaban can be given in an augmented dose, whereas if you're using edoxaban or dabigatran, you need to give them low molecular weight heparin first as a lead-in period for 5 or 7 days. I can't remember exactly which. But this study looked at a small group of patients and said, right, if we take people with PE, 131 patients with PE, we use the Hestia criteria. If they're negative, we can send them home. And they sent home 35 patients directly with rivaroxaban, and they found after 1 year no VTE recurrence and no major or clinically relevant bleeding. Now, much bigger studies are ongoing to look into that. But I think it seems like a fairly sensible approach. Then after the event, and this is by and large the time you guys are really going to get involved, I think there are a number of challenges that we've still got to face. Now, I heard David Keeling talk about this a few years ago and gave a very nice analysis of why the NICE evidence is saying that you should screen everybody for cancer is probably flawed. I don't know where, I've seen David already, so I know he's here, but I don't know if that's still what you believe. But anyway, you've certainly been supported by this study from 2015 in the New England Journal. But NICE guidance still says do it. So the question is what your hospital's approach to that is. But this was a multi-center, open-label, randomized study, randomizing people to undergo limited screening or limited screening plus CT scanning to look for like abdominal pelvic malignancy. And what they found was that if you do additional imaging with CT, you add very little. So I'm interested to see whether NICE then retract that particular recommendation, because of course for our insurance policy in the hospitals we have to be NICE compliant. So it's still my practice most of the time to request a CT in patients over the age of 40. Now, with unprovoked PE. Extended anticoagulation, 6 months versus extended. This NICE study, which looked at 6 months of anticoagulation plus another 18 months in this group here with warfarin, and the other half of the patients were randomized to placebo. And what this shows is if you extend anticoagulation from 6 months out to 2 years, the recurrence rate is significantly reduced. And this was a composite endpoint of recurrent VTE and major bleeding, so it's taking everything into account. Then if you stop at 24 months, what's interesting is this group almost catches up with placebo. It's almost like they were predestined to get their recurrence. So that catches up. So this really, I think, mandates a proper follow-up of patients with VTE and making absolutely sure that the patients who need to be on long-term anticoagulation are on long-term anticoagulation. And I think this is probably one of the biggest challenges, is making sure that our patients aren't sent out of the door after 4 hours if they're low risk, or 48 hours if they're admitted, and said, here, take rivaroxaban, for 6 months and then stop it and then you're fine. That patient needs to be followed up and risk stratified, and the balance of bleeding versus recurrence assessed. This I tend to include when I'm talking to non-hematologists, so in the interest of time I won't cover this. So there we are. That's the current algorithm for how we manage pulmonary embolism, some of the still ongoing challenges, and some of the, I think, the solutions we found to those challenges over the last couple of years. If you're interested in having that presentation, looking at it, then there's a tiny URL, Luke Howard-Prezi, if you want to go back to that, and that's uploaded, and you'd be very welcome to do that. So if we have time, I'm happy to take any questions.